Dr. Radio, because it matters where and when you get your health information. Sirius XM 81.
Leading specialist taking your calls. Powered by the NYU Langone Medical Center. This is Dr. Radio.
This is Sirius XM Dr. Radio. From the heart of the NYU Langone Medical Center, this is Healthy Aging with Dr. Michael Perskin.
Welcome to the Healthy Aging Show. This is Dr. Michael Perskin here on Sirius XM 81. We've got a great show, and we have two topics that are not related. We're going to have Stephanie Russell, who's a dentist, a doctor dentist, as I like to say. She's a periodontist and from our dental school here at NYU, and we're going to talk about periodontal disease. That'll be the second half of the show. But to begin with, I'm very pleased that we have Nancy D'Auria, who is the director of the ElderServe Home Care Services, a division of the Hebrew Home at Riverdale, which is a local skilled nursing facility here in the New York area. Has a fine national reputation, well known to me and my colleagues. And the reason we're doing that is because November is National Caregiver Awareness Month. And for this segment, we're going to talk to Nancy. So, Nancy, welcome.
Thank you.
Great. And I understand by training you're a nurse?
I am. I've been a nurse for quite a long time, and I've been in home care about 15 years.
Right. And what were you doing, mostly inpatient work before that or other stuff?
I worked actually critical care and ER before that for a long time.
So how did you make the jump? What was the thing that attracted you to this kind of work?
I liked the idea that you could arrange care for people in their homes to make it fit so that they could stay there as opposed to be facility-based.
Yeah, and it's a big problem as the population ages, right? We have lots of folks who, for a variety of reasons, may want to, as you termed it in the pre-show discussion, and so age in place, which is a pretty common sociological term, right? Aging in place, meaning that folks don't want to move when they're older.
No, that's really very true.
They're comfortable, and they have a certain amount of independence and autonomy based on their familiarity with their environment, right?
Yes, very much so.
So it seems like a good idea, and they have a social support network as well.
They really do. The age in place is a great thing as long as the safety and comfort can be maintained there. People do a lot better in their familiar environment, their familiar surroundings. I don't want to get a little bit older and go, well, that's just it. I now have to move to somewhere halfway across the country, away from friends, the stores I know, and different things. I think it goes to quality of life, too.
Yeah. It's sort of a dichotomous, right? Because there's a whole other group of people who do move to usually in the Sun Belt type of community.
Oddly enough, a lot of those people are coming back.
Yeah, when they get frail.
That's right. And so they've very often moved away from family and friends and suddenly now need more assistance in taking care of themselves at home, and they end up coming back to a familiar environment again. Yeah,
I often tell the patients and families that I take care of in my clinical practice that, society hasn't really worked this out yet.
No.
But when you describe it like they come back, it's almost like, my kids, one kid just graduated from college, the other's going to go in a year and a half. And, sort of you go to the retirement community when you're sort of ready to, go. You could be pretty healthy. And at some point you need to figure out how to leave that. But for many decades now, people didn't really think of anything beyond that because their expectation wasn't that there was going to be an after.
No, a lot of people say, all right, I'm working right now, and what I'm going to do is I'm going to get myself a retirement condo down in Florida or in North Carolina or something along there. Yes, exactly. And they are out there, and when they now need assistance with a lot of their care needs, there's no one but the people who are their age there, and it becomes very difficult for them to fly back and forth, to get together with family, to see great-grandchildren, things like that.
Yeah, it's not talked a lot about that, what happens, and it's many of those communities by design don't have robust social services sometimes.
No, they really don't.
Low taxes, which is what attracted the retirement condo business to begin with.
That's right. They have very little infrastructure to allow for those kind of care needs.
All right. So we've talked about on our show here many times. So we have an aging population that's, sort of burgeoning every day. And so we have a lot of people caring for those folks. It's November's National Caregiver Month. So how many caregivers are there out there?
There's an awful lot more caregivers out there than you would think of. You have an entire slew of paid caregivers, which are home health aides from agencies such as my own. But no one's really sure of how many caregivers there are out there that are the unpaid ones, that are the family members, the friends, the people who live in your apartment on the same floor.
Right.
Your apartment building, I should say, on the same floor. That's a real hard number to calculate. And how are you exactly defining caregiving?
Yeah, well, that's the next question. What is a caregiver?
A caregiver is someone who's providing care to another individual, but that care has so many different forms that it can go through. It can be as simple as, I need help getting to my doctor's appointments, but otherwise I'm good. I just can't drive anymore. I need assistance in the grocery store. I can't get those bags up to, the grocery bags back into the house. So what kind of assistance do you need? It may be social isolation sometimes. So you have someone, I need to talk to people sometimes.
Sure.
I feel like I'm here in my apartment and I can't get out. So there's a lot of different levels.
Yeah, it's interesting that there is I would say it may not be a majority, but it's certainly many folks who, again, age in place because their driving thing is their sense of autonomy and independence. And I would talk a lot about that in geriatric medicine, and that's a value that people have. Mm-hmm. That is just the way they're built.
It is, right.
But yet they underestimate that. Well, what do I do? I'm at home now, and even if they have a loving family, unless they're really close, physically close, in an urban area like New York, which has a lot of traffic and barriers to getting around, even a devoted family member is going to only see them, even if it's every Saturday and Sunday, and once during the week, it's just tough.
It's very hard, and especially for the generations that we're seeing now, people who have married a little later in life and therefore having children a little later. So they have children that they are still either in high school or in college and doing a lot of the running around with that, and now have parents who may be in their late 80s, and so they're really kind of divided, that sandwich generation.
And there are smaller families, right?
Yes, and there are smaller families. They really are.
So you see this all over the place. So there, the concept of how many hands there are to do work, right? When I started practice, when older people, there were fewer of them. The ones that were more likely to have, they could have 5 kids, and then. So 3 of them were involved, and 2 were sort of not really involved for one reason or another.
We're so much more mobile now this time that people live all over. They're really quite spread out.
But if you have 2 kids and one of them is unable, doesn't have the time because of their own work or other parts of their lives, putting it all on one person. So that's what we talk a lot about on the show. We see talk a lot about caregiver stress and how to support the caregivers. But as you point out, everyone has kind of a list of things that they need done. And in my field, we call those their instrumental activities of daily living. They need to shop and cook and do their bookkeeping.
That's right. They still have all of those things that they have to accomplish.
And if they can't do those for themselves, they need someone help. And to me, that's what a caregiver is.
Very often, we find that we have an influx of clients calling for either home care services or housekeeping services around the holidays, because what happens is that a family member, the son or the daughter, comes home for the holiday and realizes that there isn't any fresh food in the refrigerator there really should have been, or the apartment isn't as clean as it used to be, or, mom just seems a little off right now. And they suddenly realize, I haven't seen her in 6 months.
Right.
Talk to her on the phone, and everything sounds great on the phone. But the reality of those pieces of her life that need to get done aren't as much anymore, and they very often will look for care while they're here visiting.
Yeah, I think that's right. So, Nancy, what we're going to do is we're going to invite our listeners to call in. This is Dr. Michael Perskin on the Healthy Aging Show. We're speaking to Nancy D'Auria, who is the Director of Elder Served Home Care Services at the Hebrew Home at Riverdale, and we're talking about caregiving. So if you have some questions, or if you're not sure if you're a caregiver, or you are and you're not sure about how to handle something, you want to give us a call, please do. 877-NYU-DOCS. That's 877-698-3627. Or you may email docs@SiriusXM.com. So, Nancy, so one of the things you do is you guys are actually a certified home care agency.
We have several different programs. We have a certified home health agency, so we can work with Medicare when someone is first coming out of the out of the hospital and needs some follow-up care in order to get stronger to remain home. We also have a licensed agency as well, so we can provide ongoing care when it's needed.
Right. So I think for our listeners, what would be helpful is if you kind of gave the broader construct of that. So, to kind of put it in concrete context. So people can need home care that is supervised by nursing. Right?
That's correct.
And that is paid for by Medicare under certain conditions.
Yes.
I think what you said, one of them is when you're in the hospital for more than a few days. I think it's
3 days. Mm-hmm.
All right. So if you're in the hospital for more than 3 days, it's probably true for commercial payers as well, but certainly for Medicare. The rule might be different for commercial payers, but it's probably pretty close, I would guess.
It's somewhat close, yes. Mm-hmm.
And there's a need for certified services. With some exceptions, right? You can get it approved. Right?
That's right. A nurse comes out to your home the day after or within 24 to 48 hours after you come home from the hospital, and they do an assessment to determine that you need care that is skilled and that will help you to become stronger and more independent and be able, therefore, to stay home. Medicare
and recover from the illness. Let's say you had pneumonia or a heart attack or a stroke.
They're going to go over such things as medication administration and what your meds can and can't do for you, how to take them correctly, different things like that. They can arrange for physical therapists to come in. If you had, for example, a fractured hip and you've had it repaired and now you're back home, you need additional PT to help you with that. Or even occupational therapists. The occupational therapists do a lot with functional care at home, and they can help you to arrange things or do things in a way that allows you to be able to fully dress yourself, to be able to get from bed to chair.
And that's a really important statement, Nancy. So it's functional recovery, right?
That is right, very much so.
And so it's good for folks to think about it that way. So as an example, to function in a climate like where we are right now in New York, so what do you need? Well, you need to be able to kind of get out and about to shop. You need to be able to put on your clothing without help.
Right.
If you live by yourself. And so that is therapy, right? And then, of course, if someone was in the hospital, maybe they had blood pressure problems or they're not breathing quite right. So that's the nursing part of it. They might have a wound. Let's say they had surgery. Mm-hmm. So wound care is considered a skilled nursing service.
Yes, it is. And the nurse can come in and she can teach family members or the patient themselves how to care for the wound and provide it to a degree, because Medicare assumes that they will learn it and the nursing will come back out.
So that's the thing where, as a doctor, you get a very puzzled phone calls from folks, from family members and the patients, because they can't, not being in the healthcare profession, they can't quite get that, and they really confuse, frankly, skilled nursing things with custodial services, like, basically helping someone get up from a chair to go to the bathroom is not a skilled nursing need. Anyone can help someone.
And that's really what Medicare, the nurse who comes in to assess for Medicare, when they realize that the patient is not going to be able to progress past that point and that everything else now is just to maintain, that is the custodial aspect.
Right. And that people have a lot of trouble with that. And as a physician, I see the overlap. And the fact is, a lot of those services are provided sometimes, and it's not that the people don't need the help. It's the question of who pays for that kind of help. That's where you get into some real problems. I'm sure you deal with that all the time.
The payer sources are really a very important piece of it. Probably about 15, 20 years ago, a lot, especially in the middle class, bought long-term care insurance.
Right.
And we are seeing more and more people access that now for the very first time. They were in their 50s and 60s when they bought it, and now they're into their 80s. And now they're saying, you know what, I do need it. And it's a great product, especially for the middle class, because they very often can't afford it as maybe the very rich can, and they still make too much to be able to be on a Medicaid-based program. So it's something that we do see people use more frequently.
Right. Well, let's go to the phones, Nancy. We're going to speak to Laura. She calls from Ohio. Laura, welcome to the Healthy Aging Show.
Hello, doctor. my mother, she's going to be 90 in April.
Uh-huh.
She had an operation on her back because it was disintegrating, and they put a brace, I guess, on her spine.
Mm-hmm.
And she went to rehab. Her Medicare is done, and they said she's plateaued. And she's lived in her house for 57 years.
Mm-hmm.
She wants to go home, but she can't walk anymore. She has one arm that works. And I want to bring her to my house and take care of her.
Mm-hmm.
She lives in Michigan. I live in Ohio. And I'm just worried about, she has no short-term memory. And I just want to take care of her, but I'm worried that she's going to get upset, that she's not going back to her own home. And I'm afraid to leave her with, 24-hour care.
Because you're at a distance, so it's several hundred miles?
Yes. And
so it's not like you can poke your head in once a week or something.
No, I'm actually there right now, and I go 3 times a week. I just drive it. I'm retired, and it's my mother, so I'm devoted to her, and I want to do the best for her.
So, Laura, I'm going to ask Nancy to start, and then I'll tell you what I think of how you can sort of arrange this. So you want your mom to come, and she's a bit resistant? What's her solution? What's her solution to getting help and stuff like that?
I can get an aid, and I can get 24-hour care for my mother, but my problem with that was she did have 24-hour care, and I wasn't, really satisfied with that. And
right now, but what is your mother? When you say to your mother, why don't you just come live with me? What is your mom? Why doesn't she want to do that?
She goes, okay, but then she goes, well, let's go to my house. She wants to go home.
I see. Nancy, thoughts?
It's a very difficult position to be in, to be able to monitor 24-hour care at home. Is your home accessible? Is it going to be a good move for both of you?
Yeah, I think that, I can get to bed. I can, I have a first floor room for her next to my room. I mean, I hired an aide already. I'm just worried that she's going to get upset and be resistant.
I think that's a very valid point, because a big change in location and living arrangements like that very often can spark that.
So, Laura, my question to you is, who are the other players, if any, in there? I'm assuming your dad is gone?
Yes, my dad is gone.
Do you have any siblings?
I have. All my siblings live in Michigan. I have 2 brothers and a sister, but they work.
And so they're happy with the plan to move her to your house?
They're happy with it, or they would just rather keep her in assisted living.
Right, but they're supportive of this or assisted living. Those are their choices. No one is saying, I want her to stay where she is in her home. Is that right?
No.
Everyone realizes that's probably not a good option. And is your mom able to manage her own finances and things?
No.
So have you already sort of taken that burden from her, or there's some system in the family to do that?
Yes, I'm doing that.
And is that kind of official? Or do you just tell your mom, sign here, sign there?
Well, I'm her durable power of attorney,
right.
But what I found out...
Very good.
They want more, though. The bank wants to see that my mom is incompetent of doing that. And so a psychiatrist did evaluate her about 4 days ago, and, they said, no, she can't take care of her finances.
Right. So one strategy, so then you have the pieces, because one of the problems sometimes is in families that there's someone who's against the new plan, and they can create issues or discomfort. But it sounds like that won't really happen, so that's good. And then you have the legal part of it handled, and that your mom realizes she wants you to manage the details of her life.
Yeah.
Financial and medical details, getting her prescriptions and things like that. So, one of the strategies I tell people is you should always tell the truth, but there's no need to blab the facts. So what you could tell your mom is that she's got to come to your house until she gets better. And,
Okay.
And that's not, exactly true, but it's not exactly a lie. It is possible there could be some miracle or some other way where she gets stronger and mentally fit and go back to her home. And, and then after a while, you got to figure out how to obviously sell her home or do whatever you're going to do with it. But I wouldn't start by that discussion because that's down the road. The first thing you need to do is get her to understand she's going to stay with you for a while, and then you see what happens after a while passes.
And usually after someone has been in a living situation for a bit of time, they kind of settle down with it, and it doesn't become as much of an issue as it originally had been for you.
Okay. I think you're right because she gets agitated, and I guess that's what bothers me. I do hate to see her not be in her home. She's loved her home. She's been there for all her life, it seems like. And I hate to take her out of it, but she just, she can't manage there anymore.
Well, Laura, so what trumps everything is the safety of the situation.
Absolutely.
And so if it's not safe, then you shouldn't feel bad about it. Your mom is less worried because, frankly, she may feel like, well, something bad happens, I want to be in my home. But she's not clear on that. I have a woman I'm taking care of now in similar circumstances who, in fact, I believe is unsafe at home. But she, over many years with her daughters, has explained to them that she doesn't care about that. She's 94 now, and now she's starting to get a little demented. But she's already made that decision. She'd rather be unsafe in her home, and she was very clear with her family about that. So, they're just following through with her wishes. And even that's getting tough. And they only live, 10 miles away as the crow flies. It just happens to be in New York where it's a tough situation. But it sounds like your mom will probably be compliant if you just sort of spin it correctly. And that's what I would do. I would just say, until you're better. And then you never know what happens.
Yeah, that makes sense to me, and I appreciate you
Laura,
telling me that.
Well, good luck, and your mom's really lucky to have you around, and you're lucky that your family is supportive, because sometimes with 5 kids you get some tension in that situation. So thanks for your call.
Take care.
Next, we're going to speak to Betty, who's calling from South Carolina. Betty, welcome to the program.
Thank you very much. Thank you for taking my call.
Sure.
I guess my situation's basically over, but I've just discovered through a lot of my situation some holes probably that which will plug and maybe we need to do them individually. I guess to start, I want to take in my mom first, similar situation. The hole I talk about is my mom was a poor person, lower middle, that worked all her life, and my father died when he was fairly young.
Mm-hmm.
So she had limited income and was unable to care for herself, but did not quite qualify for nursing. So had no money for assistance. So the only answer is you got to take her. And so, we took her and happy to do it. And it turned out to be a blessing in a way that we were able to be together this year. Then followed by Jim's mother, and we took her. I couldn't say no to her. We did actually have a little bit more space. We just crowded over it. I managed to care with her as well.
Mm-hmm.
And that was the only option available for my mom. Now, his mother did have a little bit of money, but I chose to use it to help take care of her in our home as opposed to putting her in a nursing home.
Uh-huh.
Don't know how long that money's going to last or how long they're going to last. So that turned out to be good too, but it was difficult with my mother. She did too very much not want to live with somebody else, and I probably am going to be the same way. And it got to be bitter. And unfortunately, my husband became ill during this and actually passed away. And
I'm sorry to hear that. So Betty, let me just recap. So your mom moved in with you, then your mother-in-law,
right.
And they're both living.
No, my mother finally just passed away this summer.
Oh, okay. Well, I'm sorry to hear that.
She had to go to a nursing home.
Now,
you were correct. That was a wonderful way to put it. That's the way we had to put it to her was, this is what you got to do until you get stronger, and that works.
And now your mother-in-law is living with you, but your husband passed away? Did I hear that right?
Yes. And
I'm so sorry to hear that. So Betty, so you're a great example of someone who really made a lot of personal sacrifices to take care of your aging parents. So I think that's remarkable, and you must be a special person. Did you have a question though, or other than?
No, just to say that I really feel that there's a whole bunch of folks that are being left out if they don't have a loving person to take care of them.
Okay. All right,
and
Betty.
I fell into that little.
So Betty, you keep listening. We're gonna talk a little bit about that, and Nancy knows a bit about that. So thank you for your call. And so Nancy, I'll turn the question to you in a different way. So what happens when someone runs out of money and they can't live by themselves?
That is a good question, and not everyone has someone like Betty to assist them with those type of arrangements. Depending upon the state where you live, the Departments of Social Service or Medicaid will often have options that may be available to you, such as senior housing. In New York, they have senior housing apartments type of things, and in other areas, I know they have what they call almost like it's a shared residence for the elderly.
Almost like a group home.
It's a group home, yes, it is, but it is not for disabled adults as much as it is for elderly who can't live alone, but really have some skills and want to maintain themselves as socially active individuals. So we have that as available to them as well. And then from there you can move on to assisted living programs that are either privately based or that may be Medicaid-based. New York is moving into those. Those I know better than obviously some of the other states.
No, I think, Nancy, what might be helpful to folks just to kind of go up a next level. So we use words like Medicare and Medicaid, which are federal programs.
Correct.
But most of this nursing home financing and home care financing, or a fair amount of it, is through the Medicaid program. And although the monies are mostly coming from the feds and maybe more under the Affordable Care Act, the rules are set in the states. And I think that's a kind of a complexity that most people don't really think about because they live in one state.
It's very true, and it's so difficult.
So, just hearing as an example Betty on the phone, so I have no idea what the rules are in South Carolina because most of my patients live in this situation are New York, and the New York rules I'm quite familiar with. I've been practicing for nearly 25 years here. So in New York, we have pretty generous benefits, and we pay for certain services to keep people at home. We pay if they qualify, right?
Absolutely, and you really need to contact local social service departments to see what your qualifying amounts are. Even within New York, to qualify for certain programs downstate in, say, the city area is a lot different than upstate in Albany or out in the Finger Lakes area, because the cost of living really varies from place to place so greatly.
Right. I think that's tough for people to get around, and also, even the rules about what counts as monies and assets. Mm-hmm. So someone can have, a home and has a value.
Now that's a very good point, and very often people will turn to, and it's a good investment, is to an elder care attorney to assist them to determine where they actually stand with their monies and what they can and cannot do moving forward, because very often people go, oh, well, I'm going to gift this money and then my son will take care of me. And then they find out that the son would probably love to take care of them, but by gifting the money, they've put themselves out of the running on certain programs and things. Yeah. So it's a good deal to get in touch with an elder attorney, a reputable one.
Yes.
A reputable one.
Yeah.
And that reputable is a real important word there.
Yeah, very important, because the rules are very complex, and even folks like you and I in the field, you can't quite get them because there's a lot of technicalities and, again, a lot of variability based on where you live and certain data like the average income in that area and the average asset.
And as I said, even within the state there are variations on it. Yeah. Most states do have a tiered system, so you go from someone living totally independently maybe with Medicaid-based funds if they need it, or private or through a insurance carrier, they may be eligible for some benefits to help them stay at home, some housekeeping, some chore types of services, some physical or personal care issues that can help. From there, they may move up then to an assisted living or an enriched housing program.
Right.
One of the models now that's becoming more popular is a group home model, where very often you have seniors whose spouse has died and they're on their own, and they don't really want to stay in where they are all by themselves, but they're really not ready to go into a nursing home or something like that. Group homes traditionally have anywhere from 8 to 16 people in them, depending upon the size. So it has much more of a home-like or cozy feel that they may be looking for.
Right, and and then there are people in this space who have all sorts of more creative things. I had a guest here once a couple of years ago where I think it was a business. Basically, he found caregivers who vetted them, and they would go in New York, as you know, in the New York City area, real estate is at a premium.
Really?
So if you find someone who's honest and willing to kind of do some sweat equity, and you give them a real low rent, to someone who may have an apartment that they own with extra bedrooms, you could sort of see how you could get someone to be your surrogate niece or nephew. Well, that's really what it boiled down to. And sometimes it's something as simple as, walking the dogs and, helping with the shopping once a week.
Now, one of the things we haven't really talked about that I think is a big piece of this also is the communities in which you live. And very often, like you said, dog walking or something like that, there are so many service companies or service organizations in our areas that really will do a lot to assist people.
Sure.
And they often offer programs such as dog walking or trips to helping you get to the doctors, doing the grocery shopping and bringing it in. I wouldn't suggest people use services like that for their bill paying. You want to go to someone who's really, insured and vested, in that type of a program. But they can offer those types of issues, and including the socialization, getting out, doing things.
Absolutely. So, Nancy, what we're going to do now is we're going to take a short break. When we return, we're going to continue our conversation with Nancy D'Auria about caregiving. We're going to talk about some stresses on the caregivers. We've been talking a lot about the process, but we'll talk about stresses and other things on the caregivers here on the Healthy Aging Show when we return, so stay with us.
Radio, Sirius XM 81, and on the Sirius XM app for smartphones. If the traditional sounds of Christmas is your Christmas story, Sirius XM stuffs your stocking with holiday traditions. Or maybe you like rocking around your Christmas with Sirius XM Holly. Both exclusive commercial-free holiday channels begin tomorrow, noon Eastern, 9 a.m. Pacific. Holiday Traditions on Channel 4 and Holly on Channel 17.
Tuesday on Dr. Radio at noon East, helping veterans cope with the psychological scars of war. Psychiatrist Dr. Michael Aronoff discusses a crisis hotline geared to helping soldiers returning home from battle, suffering from depression, and contemplating suicide. At 6 p.m. East, Dr. Joseph McCarthy offers advice to help families when a child has a facial difference. Learn what resources are available and how to help the child prepare for the many surgeries needed to correct the issue. That's just some of what's happening Tuesday. Repeats throughout the week on Dr. Radio, Sirius XM 81.
Hey, if your satellite radio is making funny noises lately, don't pound on it. It's just because we're on more often. Okay, pound on it. We're Click and Clack, the Tapper Brothers from Car Talk, and now for the first time anywhere, you can hear 3 hours of Car Talk every weekday afternoon. And that's a good thing. Tune in every weekday afternoon to hear our best episodes on Sirius XM Public Radio, Sirius Channel 205, XM Channel 121, and if you're not sick of us by then, you can catch Car Talk on the weekend too on Sirius XM NPR Now, Channel 122.
Sirius XM Channel Spotlight.
A home for country rockers, rebels, and misfits. Hello, country.
This is Sheridan Daniels.
This is David Allen Cole.
That was Drum. This is Steve Rose.
Mellow whiskey burning down Copperhead Road. Outlaw country.
Sirius XM
ironically cool, musically diverse. Even calling him a legend might not do him enough justice. He's
David Bowie.
and he has his own commercial-free channel exclusively on Sirius XM.
The David Bowie channel.
Rare tracks, new tunes, all for a limited time, all right now. Right now, Sirius XM channel 111 and on the Sirius XM app.
A dose of Dr. Radio.
At a certain percentage of the population being protected, the illness won't spread from person to person because it'll hit enough protected people that it will just stop being spread. That's herd immunity.
There are a number of autoimmune disorders where the body begins to take on itself in a harmful way and not the normal, helpful way that our immune system functions.
Dr. Radio, because it matters where and when you get your health information. Sirius XM 81.
No referrals, no waiting room, no copay. Direct from the NYU Langone Medical Center. This is Dr. Radio.
Welcome back to the Healthy Aging Show. This is Dr. Michael Perskin, and we are speaking to Nancy D'Auria, who is the director of the home care agency, which is called Elder Serve Home Care Services, a division of the Hebrew Home at Riverdale here in the New York area. We're talking about caregiving, and we've just spent about half an hour on some of the financial pieces and the parts related to hospitalization. But if we get past that, we just talk about actual caregiving. Nancy, I thought maybe you could comment on some of the stresses that people have who are caregivers, and because November is National Caregivers Month, right?
Caregivers Awareness Month. That's
Caregivers
right.
Awareness Month. So what are some of the things that we should be aware about?
One of the biggest things is being able to take care of yourself through all of this, and it really depends upon how much you're doing and how much time you have, and all of the other things that are part of your life. And caregiver support groups, which have really become very popular and very supportive, and they're really very specific. You have caregiver support for spouses, caregiver support for children of people with dementia. Caregiver support groups for caring for someone with a TBI, a traumatic brain injury, and they can be very, very specialized that way.
Those chronic conditions have different special features.
They do, and it really helps you to be able to talk to someone who is going through those same types of things, and they very often act as that support system. Well, you know what? When Mom wouldn't take the bath, this is what we did, and then everything worked out, and we were all a lot happier, and they can actually, assist each other in that respect. And we've been very proactive in setting up support groups towards that end.
Yeah, I think that is a real kind of general trend in society to crowdsource the answers for people who actually have had the experience,
right?
Rather than a top-down solution. Although, there are usually a list of things, and so with caregivers, we've had many discussions on the show here about that. So one of the main things for caregivers is to give themselves a break because they can burn out, yeah?
There are a lot of areas that the caregivers can hopefully give themselves a break. Many areas have respite care, for example. At the Hebrew Home, we have what we call respite care beds, and people can call the nursing home and say, you know what, Mom is she can't go to Disney World with us because she just can't do that kind of walking. It's not a vacation that's appropriate for her, but we really can't leave her at home. And so very often they can go in for a 1 to 2 week period of time, and the family can relax and kind of recharge their batteries and then be able to provide care again. One of the things with caregivers also is the sleep disturbances that very often go along with this. Mom and Dad being up and down throughout the course of Mom or Dad, I should say, being up or down throughout the course of the night, and so the family is not able to rest, or the spouse sometimes is not able to rest. We find that it's one of the things that will precipitate a a nursing home admission faster than anything because they're just burned out. They're physically and mentally worn out.
Yeah, that's exactly what happens. So, Nancy, let's again invite our listeners to call in if they have questions here on the Healthy Aging Show. This is Dr. Michael Perskin, and we are speaking with Nancy D'Auria, who is the director of Elder Care Home Services, a division of the Hebrew Home at Riverdale. And we're talking about caregiver stress. And so if you've been a caregiver and had some stress or have a problem that you think we might be able to talk through and help you solve, by all means give us a call here at the Healthy Aging Show on Sirius XM 81. And you can do that by calling 877-NYU-DOCS. So that's 877-698-3627. So Nancy, I'm going to read an email now, and it's from Mary, and she writes, my grandmother is 87 years old and was just diagnosed with breast cancer. She has been living at home for a while with part-time care and is doing great. But she's decided that she doesn't want to go through the surgeries and chemo, and her doctor has explained to us that she will not live more than a year or so without treatment. How can I support her through what she will need in the coming year? So, Mary, this is a great question. I'm sorry that your grandmother has been diagnosed with something that seems like it's fatal. That's what the prognosis is. And so that's awful. On the other hand, hopefully she had 87 great years, and she sounds like she's got a new goal, which is to achieve a peaceful death. And I think that's how I would frame the question. And Nancy, do you have some thoughts?
I think that the early involvement of hospice and palliative care, if she has accepted her diagnosis, and you as a family has as well, is a really great option, because a lot of people don't call hospice till the very, very last few days, and they don't take advantage of many of the wonderful and supportive programs that can really provide those resources for being able to care for her and keep her at home with you.
Right, and I think it's important to say, Nancy, so under Medicare, which 87 years old, this lady almost certainly has Medicare, you get certain additional benefits if you select hospice. So maybe you could talk a little bit about that.
Hospice is a Medicare-covered benefit, and so that they will provide those coverages for you. They will provide coverage for a lot of the in-home programs that are being offered, and sometimes if someone needs to go into the hospital for a short period of time, or even into a nursing home to assist them with getting pain under control, or for any wounds or things like that may have developed due to the course of the illness, then you can go in for those and come back home. They will offer skilled nursing, occupational therapy. They do palliative care and palliative medicine at home.
Right, and I think it's important to frame it in, so what are they trying to achieve? So, I like to kind of break things down into simple bites. And so my view of this is the main thing that there's evidence around in folks like this is we can keep people out of pain, and we can keep them from being short of breath. At least we can try to. And those are the two things that seem to make the most difference. And there's actually some clinical evidence, some data in various peer-reviewed journals that's what really makes a difference to people.
I think you're right in that respect. A little earlier we were talking about things that go to quality of life, and certainly a quality of life staying in the comfort and security of the home you've always known, and having family members around you is in supporting what you're doing. And with this is a very, very important piece, and really goes to the quality of life and the peace of mind that individual has.
Right, and so then the final thing, Mary, I hope that addresses your email and the questions you had. And I would say, another thing that is not widely out there, but some people do naturally, is when people know that they're dying, it's terrible. On the other hand, they know that they're dying. So now's the time to think about your life and see what kind of legacy you want. And we call that legacy building. And that's one component of what people write about when they talk about having a dignified or peaceful death. So you can leave a legacy, and it might be something simple like just writing the names on the back of some old pictures that you have in a shoebox.
And just kind of, right.
Well, and describing, so Mary is the writer of this email, and so, Mary, you could spend some time with your grandmother, and maybe she's got some old stuff, and she can tell you little bits about it, and you can take some pictures of it and write it up and put it on the internet or something, or, in the cloud there, so that the rest of your family can come look at that, and so she can have a little bit of legacy. Maybe she has more ambitious plans. There's not enough in this email that describes her as a person, so we wouldn't know. But that's the kind of the silver lining side of that discussion.
Absolutely.
And so, in that same light, Nancy, before we get more phone calls. So caregiving is stressful and it's tough, but there's some good things. So what are some of the good things that people get from being caregivers? Why do people do it?
Well, there's a lot of reasons for doing it. Sometimes it starts out of obligation because this is someone who has been there for you in the past, but it very often transcends that. And it really allows you to build a closeness to individuals. I happen to be a caregiver for my parents. My dad is 92 and my mom is 87. And we talked about smaller families. I'm one of those big families. I have 7 siblings.
Wow.
So there's a lot of us around, but everybody has really become much more enmeshed in my parents' lives, and by doing that, we've really grown to know a lot more about them. And you talk about legacy building and things, and we were actually passing around a picture of my dad, who was a veteran of World War II, and some of us had never seen some of these pictures before, and he had gotten them out to show us this is, from the past and everything, and it was a very important and meaningful thing. I think one of the things that can happen, though, is that if one person is doing all of the work, it's really very difficult. And so with caregivers, I think asking for help is looking at your life and saying, you know what, I do need some help. I want to do this. I want to do it well. I don't want to be angry about doing it. I need some help.
Right, and I think one of the pieces of advice that I remember is that happens in families when folks, have divvied up the tasks, so to speak, but really there's one person who pretty much has all the tasks. And sometimes that's because they wanted to do it initially, but now they're burnt out and they don't know how to divvy it out. And if someone says, hey, can I help? No one should ever say no. Because you're also you're not giving them the chance to help.
You're not letting them participate and become part of it.
It could be something simple like, you know what, if you could just take care of the electric bills and here's some checks and make sure it gets paid every month, or call them up and put it on autopilot, or whatever you need to do with the electric bill, or something's broken in the house and it needs to be fixed. Something very specific that someone could do, and then if they do that and they come back and say, well, I need to do something else now, I finished that job, then you have someone who's going to kind of be around a little longer.
Yeah, you should never turn away help.
Yeah. But it's got to be specific, because sometimes people actually do want to help, but they really have no clue how to help.
No, and it is true. And very often you do need someone who acts as kind of a coordinator, if you will, assuming that they have that kind of time. Or maybe you look towards geriatric care management to help you to assemble that kind of a team or put those people together for you. But you should never turn in, especially family, because you rob them of that time.
Yeah, and they may think you're too bossy, and that's why they're not jumping in, or that you want to own all the helping that's going on.
It's not right. It should be a shared thing.
Absolutely. So we're gonna read another email. It's from Helen, and Helen writes, my dad is 85 and lives at home, but the house is a mess, and it's starting to concern me that he's having some mental health problems, like possibly hoarding. He says he's fine and that he can take care of himself, but I don't think he can. I'd love to have someone visit him a few times a week and maybe help with housework or errands. How can I approach him when he's resistant to strangers coming into the house? So, Helen, that's a great question. And Nancy?
The resistance of having people come in, it comes from 2 areas. One is your dad probably is somewhat aware that his house is a mess, and he doesn't want strangers or other people coming in and seeing it because he knows he may be losing control of that part of it. And the second is the security issue. They're afraid to have strangers come in. They may steal my stuff. They may take things or whatever else. One thing to do is, if you're going to have someone come in, have it be kind of transitioned in. Have it be someone that you're there when that person is there. You introduce them. This is so-and-so. He's going to be coming in, and you're there. Maybe it's for the first 3 or 4 times until that person is a friend and isn't a stranger coming in. And that may be somewhat helpful just to assist in that way.
Yeah, I think that's a great suggestion. And that's a tough group. The patients who kind of stack stuff up.
Yeah.
Because usually that's been going on for a long, long time.
Yep.
And it's a very hard behavior to change, and very resistant to treatment.
And you're very fortunate that that the writer here is beginning to notice this, can actually take kind of help with this before it becomes a huge problem. Sometimes it's not known until the individual has a fall or injures themselves in the home.
Or the house catches fire or something.
Exactly. And then suddenly they can't go home from the hospital because the house is totally unsafe.
Unsafe, yeah.
Right.
All right, well, let's turn to the phones, and we've got Tiffany on the line from Vermont. Tiffany, welcome to the Healthy Aging Show.
Hello. Thank you for taking my call.
Sure.
I am just listening to your show, and I found myself actually in a similar situation that, well, I guess the main reason I'm calling is because I've been feeling a lot of sort of frustration and anger the past few weeks. I have my mother at home with me. She's 74 years old. She's got several health issues, but she's still very functional. But her issues are significant. She's got some renal insufficiency. She's got congestive heart failure. She's very thin, but she stays active. She likes to work in the garden, but that includes pulling weeds, sitting out there and just pulling weeds, and she'll do laundry, and she doesn't like to cook, but she stays at my house. Both of my husband and I are working. And she's gotten to the point where I feel like we're getting to a transition period of I'm not so sure she's that safe being on her own, and I think she's in some denial, and I don't know who to turn to get some help. I feel like I need somebody there.
So, Tiffany,
to check on her during the day or
let me just get a little more background. So,
okay.
your mom, it sounds like she's got the main medical problem is heart failure and the kidney problem. So, when was the last time she was well and independent and not living with you? How long ago was that?
Oh, it's been a long time.
A year, 2 years, 10 years?
She's been with me for about 7 years.
So 7 years ago she was 67, and prior to that she was healthy. Did she have a heart attack or something sudden?
Yes.
So
I don't know how sudden it was, but yes.
Well,
yeah,
but anyway, she was living independently, which is what you would expect for a woman in her mid-60s, right?
Mm-hmm.
And then she had a sudden event that led to a hospitalization. Is that accurate?
Yes. I mean, she when she was with me before, she was healthy. She doesn't, I don't have my father anymore. Anyway, there's a lot of issues as to why she's living with me, but she's progressively gotten to the point where she's getting, more difficult to, I shouldn't say more difficult, she's getting less independent. And I think that we have a
Okay, so Tiffany, so with that, I sense that you're hesitant to kind of go through the whole detail, which is fine. We don't need that. But it sounds like your mom was living with you, but was more or less fully functional and wasn't taking a lot of your time. And now, over the last period of a year or two, it's been building up, and she's becoming frail, is usually the terminology. And is there a medical reason for this? Because 74 is a little young for this kind of syndrome.
Exactly. Well, I think it's mostly her heart. That's what she also has. She's a breast cancer survivor. She's a bladder cancer survivor. She has had repetitive UTIs because of her bladder. She's self-cast now, knitting in a pouch. She's got, and that's, when she goes into the hospital.
Does she have any cognitive problems? Is she depressed, or does she have dementia?
She is depressed, and what I feel like I'm seeing is some, you hear about these early changes of dementia where.
And do you go with her to her physician?
I do.
And so you have a good relationship with the doctor?
Yes, if I'm not able to go, we talk through emails and things if need be. Yes, and I'm actually a physician as well, so which makes it, I think, more difficult because I know too much about the situation, and that makes it hard for me to make the decision sometimes as to whether I need to take her to the ER versus to see the physician because I see her getting sick.
And so the basic problem is that you think your mom needs sort of like an aid when you're not there?
Yes.
And what is the barrier? What do you think the barrier to that is?
We don't have that much available out here. I live a little bit on the outskirts of the where the hospital is. About 20 minutes out of the main hospital where she gets her care. And even though we've worked with VNA, we've worked with some rehab.
But you don't think your mother wouldn't be resistant to that, and you could afford that, or she could afford that?
She's resistant.
So because you know, it seems like you could, you know, I'm going to ask Nancy to jump in and give some answers here, because it seems like unless your mom was completely resistant and you know, or you couldn't afford it at all, that you know, in this economy, you should be able to find someone to come in and do a little, you know, aid, especially with a doctor in the house, to do some close supervision, you know, or an oversight. So Nancy?
I would agree with you. In your area, you know, there are a couple of different ways you can go. I am the director of a licensed home care agency, so my predilection is to move towards the agency route, because the individuals that you're going to get from an agency is several things. One is they're going to be totally vetted. You're going to know if there's any criminal background. They do drug testing. There's a whole system in place to try and weed out people that you would not want in your home. Additionally, you can arrange the hours usually with an agency. So, you know, say, you know, you're out of the house from 8 to 5 or 8 to 6, let's say. Maybe your mom sleeps a little bit in the morning. You can say, all right, I just want someone there for lunchtime. They can come in around 11, make sure she took her morning meds, make sure she eats lunch, get her set up or whatever, make sure she showers or dresses or whatever for the day. And then she could be on her own again for a couple of hours in the afternoon. It doesn't have to be someone there as constantly. If, you know, I don't know your area, I don't know how rural an area in Vermont that you are, but, you know, with that in mind, you could also go through a local church or a synagogue and try and find someone who, if your mom doesn't need a lot of physical care that requires a trained individual, then you might be able to find someone on more of a companionship level.
So, Tiffany, and the other thing, because I sense in the tone of your voice a lot of frustration and some uncertainty, like you don't know quite what you want to do about it. So as a fellow physician, I'd encourage you to go talk to someone about that, because sometimes, you know, and I'm assuming you're not a geriatrician, doctor, but, you know, it's not your area of expertise. So you're uncomfortable with some of the decisions you're making. In fact, you said that. So my advice to you would be to go talk to someone who you trust. Could be a colleague or who's been in a similar situation, or could be even, you know, a psychologist, a psychiatrist, to kind of get your own thoughts straight and take the tension out of it. And sometimes that's very helpful, and then you can just execute on whatever plan you come up with. So I thank you very much for your call. And Nancy, it's been a great hour. We've had a really good series of discussion about caregiving, so thank you so much for coming on.